Um, the majority of our work is really similar to what Dr. Rodriguez is doing. And we do a lot of research on trying to improve the outcomes of transplantation. And most of that work is very gradual. We have studies on reducing infections, on preventing infections. We have studies on identifying better donors, better recognition of subtle differences between donors and how to choose the best one. We have studies on preventing graft versus host disease, on ameliorating graft versus host disease. We have studies many times on identifying older donors or how to address the situation of the older patient, and that may be the biggest difference between what I'm doing and what Dr. Rodriguez presents here, because the older patient constitutes a major challenge. Many of the hematological malignancies for which we use these transplants occur more as we age. The average age of a patient with leukemia is around 60. And so many patients are between the ages of 60 and 70, 70 and 80. And transplant was developed really in patients under the age of 30. And when I started, transplant was mostly performed in younger patients. And really our challenge in the United States has become how to transplant older patients, because they need it, they have bad leukemia, and it's their only cure. And furthermore, they're healthier than they once were. The advances in other areas of medicine have really, over the last 20 years, impacted the quality of life of older patients in a dramatic fashion. The cholesterol-lowering agents, the avoidance of smoking, treatment of hypertension, physical activity, better diet, and so forth, now has resulted in a large group of patients who are in their 60s, and 60 is the new 40, they say, and everybody, but it is not, because these patients still get leukemia and they still get problems, and now they come to us and get transplant. And I am convinced that that will happen here too. And it will lead to an explosion in transplant numbers. So she was telling us that she has 4 rooms. We also had 4 rooms. Now we have 19 rooms. And she was telling us the oldest age for allogeneic transplant is 55. At my institution, it's 75 probably. And that's not because we are better, but because the patients are demanding more. And we are probably a couple of years only ahead in supportive care. But that is really where a lot of the daily advances happen and where the challenges lie. But with that, that's not what I was going to talk about. What I was going to talk about were some very cutting-edge advances, a couple of examples of very spectacular advances that really are becoming reality. And my first slides are really an overview of what transplant is, and I recapitulate here what Dr. Rodriguez already said. Transplant is a transplantation of a hematopoietic stem cell, and that stem cell can give rise to the various progeny, the megakaryocytes, white blood cells, red blood cells. We used to collect via bone marrow harvest, as she already explained. And as you see, we use the same machine here in the United States that you use here, only the patient is different for peripheral stem cell collection. And then there is autologous transplant, and she already explained that, where we collect the cells through apheresis from the patient. We sometimes manipulate them in the lab. We cryopreserve them. Then we give the patient a high-dose chemotherapy and return the cells to the patient. And there's allogeneic transplantation, where we have a recipient typically with leukemia or lymphoma, but could also have a so-called benign hematological disorder, for example, sickle cell disease or thalassemia. and we find a donor, and we collect the donor, and we transplant the cells into the patient after conditioning therapy. Problems with the previous issue are technical problems with the cryopreservation and the collection of the cells. More complicated than it looks, but very well solved by our laboratory people. An overall safe procedure. Problems with this remain considerable. One needs to find a donor who is compatible, and we only touched upon that, but that donor could be an HLA identical sibling, or it could be an unrelated donor, a cord blood donor, a haploidentical donor, and the HLA identical sibling, somebody who shares the same HLA type inherited from father and mother, is the ideal donor, and I'll come back to that in a second. And then, once the donor is transplanted, the cells can be rejected again, or they can grow too fast. They come with the donor's immune system, and they can cause graft versus host disease, enfermedad injerto contra huésped. And people remain immunosuppressed for a long time and remain at risk for infections. This is the central challenge of allogeneic transplantation. It was shown a long time ago that the success of allogeneic transplantation depends very much on identity between donor and recipient of the HLA molecules. The HLA molecules that are the major histocompatibility antigens and involved in graft rejection and in immune recognition. And there's 6 of them, HLA A, B, C, DR, DP, DQ. And they are highly polymorphic, meaning that there's many, many different alleles in a population of HLA alleles. There's now hundreds of recognized differences between HLA alleles from one individual to the next. Each of us have 2 HLA-As, one from father, one from mother, 2 Bs, 2 Cs. Similarly, B is polymorphic, C is polymorphic, and so forth. And it has been shown that the risk of graft versus host disease, the risk of the likelihood of successful transplant really depends on identity between donor and recipient here. The likelihood that any of us here in this room is HLA identical is close to 0. It's probably 1 out of 100,000. But fortunately, all of these HLAs are encoded on chromosome 6, and therefore within a family, it's like the laws of Mendel. It's like the peas, the blue peas and the white peas, and one inherits half of one's genetic information from father and half from mother, and therefore I inherit the blue set and the red set from mother, and my 5th sibling inherits the same, and therefore 1 chance out of 4 that we are HLA identical. Those are the best donors. It is because of few of us having these donors that we go to the registries and need 26 million people in the registries, or that we look for umbilical cord that is more forgiving, or that we look for haploidentical donors, and by definition our father and our mother always share at least 1 haploidentical gene with us. Our siblings also can. Now, what I really want to talk about is these 4 topics. Gene therapy for sickle cell disease, a little bit about conversion of endothelium to hematopoietic stem cells, a little bit about how people are now managing to grow blood or starting to manage to grow blood, and lastly about what Amita already talked about, CAR T cells that are recently, a week ago or 2 weeks ago, approved in the United States for treatment of childhood ALL. So gene therapy for sickle cell disease, why? So you are probably, most of you are familiar with sickle cell disease. It's a genetic disease, very prevalent in people of African American descent, but also in Mediterranean populations. We see people from Saudi Arabia and from North Africa with sickle cell disease. and it is due to a mutation in the beta globin gene at position 6. Glutamic acid is an amino acid sequence. Glutamic acid is replaced by valine, and in C beta globin, it's replaced by lysine. So one amino acid difference in the hemoglobin gene that is genetic protects from malaria and therefore has persisted in human populations for a long, long time, but also leads to sickling of the hemoglobin. The hemoglobin in the cell polymerizes and causes sickling, and that causes vascular crisis, particularly when the blood deoxygenates and we get hemolysis, we get anemia, we get vaso-occlusion. I don't think I have to explain this to you how bad a disease this is. And we have it here in Costa Rica, we have it also in the United States, and we have it over the entire world. And it's in a way getting to be a worse disease, because in the old days a lot of children died in childhood. Now people survive more in adulthood with a lot of suffering. And this is an important slide. This is already from 1994. This is life expectancy of people of African American descent without sickle cell disease in the States and with sickle cell disease. So people now, some die in childhood, but very few. But people die over time and have a reduced life expectancy and often a miserable quality of life. So it's a genetic disease of the hematopoietic stem cell, or it only has its adverse effects in the hematopoietic stem cell. So reasonably, one could offer an allogeneic transplantation. And I'm not going to go into this, but this has been done for many years, particularly in young children. But there are major challenges with this. It can be done, but you need an HLA identical sibling free of sickle cell disease, or you need an unrelated donor, which is hard to find in a sickle cell patient because of the genetic or the racial linkage between, the ethnic linkage between HLA and between ethnicity and HLA. And we find matching unrelated donor in only 20% of our African American patients. So this has been difficult and dangerous, and some people have been cured, other people have died. So what if we could take the patient's own cells and put the normal beta globin gene into, oh, sorry, I must have done something again. Okay, if we put the normal beta globin gene into the hematopoietic stem cell and either took out or prevented expression of the abnormal beta globin gene. That has been a dream for a long time, but gene editing techniques have improved dramatically over the last couple of years. There's something called CRISPR-Cas that I don't show here that has revolutionized gene editing techniques across the world, at least for lab research, and probably in the future will do so for clinical research. But this is a slightly different technique, something called TALEN, transcription activator like effector nuclease. And one can, with this nuclease, this enzyme that cuts DNA, attach a primer that recognizes certain stretches of DNA. One can treat a patient's cells with this and ideally excise a section of DNA that is of one's choice, that is targeted by the sequence of one's choice. By using this technique and similar ones, and don't ask me too many questions about the technology of this, because this is far outside of my experience, but a lot of work has been done on advancing this, and the idea then becomes that we take the sickle cell patient, take his or her stem cells, manipulate genetically these stem cells to inactivate the sickle cell gene and introduce a normal hemoglobin gene, and thus correct the patient. Here it is shown again. You have an individual with sickle cell disease or beta thalassemia. We isolate the hematopoietic stem cells. We express a functional beta globin gene and target globin gene regulators to inhibit the abnormal beta globin gene, or there's other variants of this, but the bottom line is we try to genetically manipulate the stem cells to introduce expression of a normal sickle cell globin, and so that before therapy the patient has all normal cells except the erythroid cells are abnormal. After therapy, he or she expresses normal beta globins. Those trials are underway, and the first successful patient has been reported a couple of months ago, again in New England Journal of Medicine, and I should have given you the citation, but what you see here is the after transplant, after introduction of a genetically manipulated sickle cell, genetically manipulated erythroid precursor or hematopoietic precursor, over time, both in the peripheral blood and in CD34 cells, over time, these are months, and I believe that's 3 months, 6 months, 9 months, the patient continues to express in the hematopoietic progenitor, CD34 cells, and in the peripheral blood, this modified gene. And at the same time, again, over time, one sees in black here the appearance of a genetically modified hemoglobin. And one sees also that the patient maintains a steady hemoglobin of 10 grams per deciliter, which is much higher than it was before, and complete resolution of crisis. Now, this is one patient, I believe. I think this trial had 10 or so patients, and the trial was really unsuccessful in most of them, but in one patient it was successful, and this really opens the possibility of technical modifications and improvements, so that we all anticipate that over the next 5 to 10 years this will become a reality in one way or another for patients with sickle cell disease, which would be a dramatic improvement for such patients. One of the problems we have, and we are actually participating in some of these trials, or at least on the side, one of the problems with this is how do we collect their abnormal stem cells? Mobilizing stem cells in a sickle cell patient is not so easy. Just the act of giving them growth factors to mobilize the stem cells and doing the apheresis can provoke a crisis that has been fatal. And others, including Dr. Rafi at our center, are working on improving the efficiency of these processes. And I thought I'd show you this because it's a spectacular example of how conversion of adult stem cells from one lineage to the other is really possible. I talked to you in my earlier talk that there's always been hints that stem cells, adult stem cells, can convert to another lineage, but that the efficiency of that is quite low. Why, we don't know, and that's therefore not recommended to use adipose stem cells for treatment of retinal diseases. But at a laboratory level, Dr. Rafi has been able to show that by taking, I'm just going to limit this to 1 or 2 slides, but that by taking endothelium, one can, by virtue of introducing certain gene modifications, convert that endothelium in hematopoietic stem cells that have pluripotent hematopoietic capability. Would one do such a thing because it's much easier to grow endothelium and much easier to transfect the endothelium than it is to grow and transfect hematopoietic cells. When one starts with ES cells or iPS cells and tries to grow hematopoietic cells, the efficiency is quite low and the technical hurdles are enormous. Dr. Rafi's dream is to grow, to use as a starting material hemogenic endothelium, which is easy to grow, easy to transfect with a gene of interest, let's say sickle cell disease, then convert it without going back through the stage of iPS cells into a hematopoietic stem cell and have a product ready for gene therapy. The way he does that is by transfection with these genes and growing this on a layer of vascular endothelium. So he uses a vascular niche to grow, and the vascular niche gives angiocrine signals that instruct the hematopoietic stem cells that arise from this. So you start with an endothelium, you genetically transfect it, and by providing the right signals, over time you grow hematopoietic stem cells from the endothelium. Again, this is for the future, although there are trials planned with this product to try and use this product for large cell expansion of hematopoietic stem cells. And I think this is one of the ways in which this will move the field further with higher efficiency. Third, couple of words about iPS-derived platelets. So platelet transfusion, very important in a lot of situations for treatment of leukemia. Some people have shortage of platelets or have antibodies against platelets, or we cannot find the right platelets. One of the efforts ongoing, mostly in England, by a researcher, Dr. Gevaert, is to again use iPS cells and provide them with the right instructions to develop into megakaryocytes, and megakaryocytes that clearly look like megakaryocytes here, that then can result in platelet formation. So again, a couple of years off from reality, but the future may well be that we have banks of megakaryocytic progenitors that can be converted into platelets for daily transfusion. So that could revolutionize the blood banking industry over time, and would, for example, also take care of issues like HIV and hepatitis that we transmit with blood transfusions on a regular basis that cause enormous problems. But last, one spectacular advance that has really become reality and is rapidly going to change the field of treatment of lymphoid leukemia and lymphoma is the CAR T-cells. And let me spend a couple of words on that. So again, going back to what Dr. Rodriguez talked about, allogeneic stem cell transplantation, we have a donor. Part of the efficacy, part of why we cured the leukemia in this recipient is the conditioning regimen, but a big part is also the donor cells, and particularly the donor T cells that come from the donor. They cause graft versus leukemia effects. As a side effect, they also cause graft versus host disease. Let me show you how this is experimentally proven or in the clinic proven. This is an old report on a myeloma patient who gets an allotransplant and goes into remission, as shown here by disappearance of the abnormal protein. So the patient goes into remission, but then the patient fails and relapses again. And then we just administer more T cells, just an infusion, a donor lymphocyte infusion, and we elicit another remission that is durable. The price to pay is graft versus host disease of an acute and a chronic nature. So the observation is there, the observation is fascinating, we see it regularly, but we see also a lot of side effects of it, and we see it also fail it very often spectacularly. So it's a toxic, incomplete, partial treatment that needs improvement, and that I always consider proof of principle, but not much more. This is another spectacular example of a patient with lymphoma who has progression after his allotransplant. Then we gave him cells, and after the lymphoma disappears completely. Now, again, spectacular, but this is a slide that I made 20 years ago, and I still show the same slide. It shows how rarely this happens. It's not like I have to see this happening in every patient, but it can happen. So how to improve it? This is mediated by the T cells, and the T cells react with antigens on the tumor cell. The antigens can be expressed by MHC, or, sorry, I need to correct this. I'll take a step back. The T cells mostly interact with the tumor by antigens present on the surface on the tumor and presented by the MHC molecules. But there's other antigens that are present that are characteristics of the cell surface of the tumor. That's not well shown here, but they are markers such as CD19 in ALL. They are not directly recognized by the T cell, but they are recognized by antibodies. Antibodies recognize entire antigens on the surface of a tumor cell. Now, antibodies do not have much anti-tumor activity. They do attach to the tumor, and sometimes they have some effects against the tumor, but minimal compared to the T cells. However, the T cells require recognition in combination with this MHC, and this MHC is polymorphic. It cannot be used from one patient to the other. Why not combine the benefits of an antibody, the recognition of an entire antigen on the cells, and no patient dependence, no restriction, with the advantages, the powerful effect of a T cell. So what people did, there were a number of groups across the world who developed variants of this, and they are now all arguing about who deserves the most credit, but I believe a number of people deserve credit for this. But the brilliant idea that turned out to work was that they used a chimeric molecule, a molecule with two origins. A chimera is the mythical Greek person that was half animal, half human. This is a molecule that was designed that is half a T cell receptor, the intracellular part, and half an antibody. So it's derived from a B cell antibody, and it recognizes CD19, but it signals to the T cell to get activated. And there's variants around of these molecules. This is the one from Memorial Sloan Kettering, the NCI, and the University of Pennsylvania. That were the three centers that really pushed this the most. These cells get introduced in the patient's own autologous T cells. So we collect the T cells from the patients. We send them to the company that does this. This is Novartis, this is Juno, and this is Kite. There are now 3 companies. And they will take the cells of our patients, genetically manipulate them, introduce this CAR T cell receptor, now directed against CD19, grow the cells in the lab, and send them back to us. So again, take this away, this is not correct. We just have a patient with acute lymphocytic leukemia or B-cell lymphoma. We collect cells by apheresis. We send them to the company. They insert the CAR T gene. Takes 3 to 6 weeks, depending on the company. Send them back to us. We give a rather mild chemotherapy with the purpose of supposedly lymphodepleting, taking out the patient's own cells, and give these cells back. And the results can be spectacular. And I have been fortunate to treat a couple of patients like this. But in ALL, B-cell ALL, what happens almost invariably is refractory B-cell ALL. These are all blasts in the bone marrow, all the same cells. And you see that all these cells express CD19 on a flow cytometry. And that's the marker of the B-cell ALL, and this CAR T-cell receptor is directed against the B-cell molecule. Day 8, no longer any lymphoblasts, no longer any CD19 positive cells. Day 50, recovery with megakaryocytes, normal myeloid cells, red blood cell precursors, and no leukemia. So this procedure causes complete remissions in over 80% of refractory ALL patients. It also causes remission that seems to be prolonged in about 30% of refractory large cell lymphoma patients, and that will be the second indication for which it will be approved. This procedure is not easy. I have treated 3 or 4 patients with this product, and yes, it works, but yes, it is also very toxic at this moment. People get massive fevers. They get what is called a cytokine release syndrome. They get 40 degrees fever that lasts for 2 weeks sometimes. They also get, they can become hypotensive. They really behave as if they have septic shock. And of the 3 patients that we treated, all 3 had to spend time in the intensive care unit. They also have a strange neurological syndrome where patients become aphasic. They cannot talk anymore, and some patients have gone into a coma, and that affects like 20% of the patients. And there have been some deaths from cerebral edema. So this is spectacular, but this is also not perfect. This will really take off and has posed a lot of, as Dr. Wickrama said, they are the only center in Chicago, so across the US, certain centers are recognized as centers that have the expertise to do these types of treatments, and we will be all overwhelmed with a large number of refractory patients. Over time, this will improve as far as toxicity and efficacy, but this is a dramatic advance in cell therapy that really will change the world. The next step, one big disadvantage of this is that we need to get the patient's own cells. And with the patient's own cells, it takes time. Patients have leukemia. They need to be expanded. The next step may well be that we get a healthy donor whose cells get the CAR T cells inserted and further inactivated so that they cannot attack another person, and so that now we can treat the patient directly with an off-the-shelf product. So no longer collecting cells from the patient. So what we do here is we take a normal donor. Oh, sorry again. Well, it was my last slide. We take a normal donor. Oh, this is going to... And this is... Okay. We take a normal donor. We insert the CAR T cell receptor, but we also excise their own T cell receptor. So this is a cell now that can recognize only the leukemia and nothing else. And here in 2 patients with ALL, I'm not going to go through the details here, but 10 patients have been treated like this. And it is an off-the-shelf product. When people are really sick, you can get the product right away. And there have been beautiful responses in B-cell ALL patients who had failed every other treatment. We are actually running a trial right now of this very product with a CAR T that is directed against AML, against the CD123 receptor. And there again, it seems to have some activity. A lot of people are working on variations of CAR T and on improving this, finding new indications. And I think this is a story that will exponentially expand over the next couple of years. With that, so there are rapid improvements in technology. We are at the brink of correcting hereditary disorders like sickle cell disease, and CAR T cells are already reality, but will undergo further technical advances and will find other indications. With that, thank you very much.